Hello and welcome to this session. Today we are going to look at characteristics of a diseased state, and the objective of our session include the following. We're going to give an overview of inflammation, describe the systemic effects of inflammation, identify mediators of inflammatory response, describe wound healing and repulsion, and describe the process of edema formation. Right? So, welcome to the session and let's get right into it. Inflammation is generally referred to as a protective response of the body's tissues to either injury, infection, or irritation. And inflammation normally aims to eliminate the cause of cell injury, clear out damaged cells, and initiate tissue repair. So, this response involves the immune system, the blood vessels, and other molecular mediators. Inflammation can be short term or long term, just depending on the duration and the cause. Talking of the acute inflammation, this one is normally short-term response that usually resolves once the harmful stimuli has been removed, and it typically lasts about a few days. Examples could include a sore throat, a skin cut, or an allergic reaction. Chronic inflammation, on the other hand, is when the inflammatory response persists for weeks, months, or even years, and it can lead to chronic inflammation. This can occur when the cause of inflammation is not removed, like for the autoimmune infections or chronic infections, or if the body overreacts to a stimuli. Chronic inflammation can contribute to diseases like rheumatoid arthritis, Crohn's diseases, and certain types of cancer. We have some characteristics of acute inflammation. You find that acute inflammation is normally rapid in onset. It just begins within minutes of injury. It is of short duration, like a few minutes to a few days. And when during this acute inflammation, we normally have blood vessels becoming more permeable, and when they are permeable, they allow proteins and fluid to leak into the surrounding tissues, and this normally leads to swelling, which is one of the cardinal signs of acute inflammation. Neutrophils, which are a type of white blood cells, are normally the first responders to the site of injury, and they are key in clearing infections and removing dead tissues. Neutrophils are normally replaced by macrophages. So we have to know the cardinal signs of acute inflammation, which are mainly five. We have redness, which is the rubor, right? And this is increased blood flow to the affected area, causing redness. We have heat, that's calor, and the influx of warm blood to the area raises the local temperature, hence the heat. Swelling, which is tumor, and this one normally results from the leakage of fluid and plasma proteins into tissues, causing swelling. Pain, DOLA, you have inflammatory mediators like prostaglandins, which become sensitive to pain, to pain, and this causes pain. Loss of function, that's the fascial lassa. We have swelling and pain, which may limit the function of this inflamed tissue, and this could result into the loss of function. Maybe we could look at each of them so that we start with the pain. And pain is one of the hallmark sign of inflammation, and it occurs due to several factors. First of all, we could have inflammatory mediators like prostaglandin and bradykinin that we have mentioned. When they are released by damaged tissues and immune cells, these chemicals normally increase the sensitivity of nerve endings, hence causing pain. Number two is that as fluid accumulates in the affected tissue, it normally exerts some pressure on the surrounding tissues, including the nerve, and this could result in pain. Remember, pain normally serves as a protective mechanism, which normally signals the individual to avoid further use or injury to the affected area, and this will promote healing. Number two is redness, and redness occurs when there is increased blood flow to that affected area, Remember, this process is what is referred to as hyperemia, and it could be caused by a number of factors. Let's say vasodilation. So, this is where chemical mediators, especially histamine and nitric oxide, normally cause blood vessels in the injured area to widen. That is vasodilating, and this one will allow more blood to flow to the site of inflammation. So the increased blood supply normally brings more immune cells, more nutrients, more oxygen to the site, and this will help combat the injurious agent and initiate repair process. This rush of blood to the area normally results into a visible redness. Number three is the immobility or loss of function. So this loss of function can occur at the inflamed site due to several factors. Let's start with the pain and swelling. Pain may limit movement to avoid further injury, and swelling can physically impede the movement of muscles, joints, or other structures. If you have the tissue damage, in case of more severe inflammation, tissues may be damaged to the extent that they temporarily or permanently lose their function. So immobilization is protective in nature, as it prevents further injury or strain on the affected tissue and promotes healing. In chronic conditions, however, it can be a problem, and this could lead to long-term disability or dysfunction. The fourth cardinal sign of inflammation is swelling or edema, and it normally results from accumulation of fluid in the tissues. It could occur because of several reasons. We have the first one, when we have increased vascular permeability, where inflammatory mediators like histamine make the blood vessels to be more permeable, and this one normally allows proteins and fluids and immune cells to leak out of the bloodstream into the tissue spaces. Swelling normally helps to dilute toxins, bring immune cells to the area, and initiate the healing process. However, if it is excessive, swelling can cause discomfort and limit movement of the affected areas. The last cardinal sign of inflammation is heat. Of course, it's another sign of inflammation that normally results from increased blood flow, that is hyperemia to the affected area. When you have increased blood flow, this normally happens as the blood vessels dilate and more warm blood from the body's core flows to the affected area. The tissue temperature normally rises. So this warmth is beneficial because it normally aids the immune response by increasing the metabolic rate of the cells, speeding up the removal of harmful agents and facilitating the healing process. Heat can also create an environment less suitable for some pathogen to survive, and this will fasten healing. Right? All right, now we can proceed and look at some of the causes of acute inflammation. The first one is infection. It could be bacteria, viral, fungi, or parasitic infection, which can trigger inflammation. Another cause is tissue injury, where we have physical trauma, burns, or cuts, which can lead to an inflammatory response, or chemical irritants. You find that exposure to toxins or irritants can initiate the process of inflammation. Lastly, we have foreign bodies like splinters, the sutures, or other foreign substances in the tissue could cause acute inflammation. So the process of inflammatory response can be summarized into 5 steps, which are summarized by the 5 R's. Okay, so we have the 5 R's of inflammatory response. The first one to take place is normally the regulation of the recognition of the injurious agent. I beg your pardon. So here you find that the body first recognizes the harmful stimuli. It could be bacteria, a toxin, or a tissue that is damaged, and this is normally done through pattern recognition receptors on the immune cells. Then now we have now the recruitment of leukocytes. So once the harmful agent has been recognized, immune cells will be activated and inflammatory mediators are released, leading to recruitment of leukocytes, especially the neutrophils, which are later replaced by macrophages. Then takes us to step number 3, where we have the removal of the injurious agent. Uh, Leukocytes will clear the harmful stimuli through processes like phagocytosis, which involves engulfing and digesting pathogens, and the release of enzymes and reactive oxygen species that will destroy microbes. Regulation, that is the fourth step. and involves the control of the response. Inflammatory signals are tightly regulated to prevent excessive tissue damage. So we have anti-inflammatory signals such as the release of cytokines like interleukin 10 and transforming growth factor beta. This one normally ensure that the inflammation does not continue uncontrolled, because if it does, it could result into other unwanted side effects. Right. Lastly is resolution, and this one also involves repair. So once we have the harmful agents being cleared, tissue repair mechanisms are initiated. So damaged tissues will be removed, and new cells are generated through regeneration or repair to restore the tissue integrity. So we have the sequence of events in acute inflammation. So we have the first one, vascular changes, then that leads to cellular events, and then exudation. In vascular changes, blood vessels normally dilate to increase blood flow to the affected area, and the permeability of blood vessels increases, and this normally allows proteins and fluids to move into the surrounding tissues. On cellular events, neutrophils, as we have indicated, are normally the first leukocytes to reach the site of inflammation. They are then followed by macrophages, which help phagocytose and repair the tissues. Lastly, we have exudation, where we have fluid and proteins, including immune factors, will exit the bloodstream and accumulate in the affected area, forming an exudate. This normally results in swelling, which is one of the cardinal signs that we have just discussed in our introduction, right? Okay, so what are some of these mediators that normally help aid the process of the inflammatory response? Well, we have a number of them. The first one is cytokines, which are small proteins produced by various immune cells and do play a central role in signaling during inflammation. Let's say interleukins or the tumor necrosis factor alpha and other interferons, all of them, they mediate the inflammatory response. Number two, we have chemokine, and chemokine are mediators, a subject of cytokines that specifically regulate migration and activation of immune cells to the site of inflammation. So chemokines normally help recruit white blood cells to the affected area, and white blood cells will be very key, especially in the neutrophils, for phagocytosing the injurious agents. Prostaglandins is the third mediator. Prostaglandins are lipid mediators which are derived from fatty acids and are involved in promoting inflammation, vasodilation, and pain sensitization. You find that NSAIDs normally target prostaglandin synthesis, right? If you are using them as painkiller. Leukotrienes are the fourth one, and they are also lipid mediators derived from arachidonic acid and do play a role in inflammatory response, particularly in conditions like asthma and allergic reactions. Histamine is released by mast cells and basophils during inflammation. It causes blood vessels to dilate and become more permeable, leading to redness, swelling, and increased blood flow, which are the cardinal signs that we have just discussed in the previous slide. Bradykinin is a peptide that causes vasodilation and its increased vascular permeability. Bradykinin contributes to pain and edema at the site of injury. We have other mediators like the complement system, acute phase proteins, nitric oxide, proteases and enzymes, interferons, and eicosamides. All these are some of the mediators of inflammatory response. All right. Okay. Vascular changes during acute inflammation we are divided into several stages, where the first stage we have transient vasoconstriction, which normally lasts for seconds to a minute. It normally occurs in arterioles due to the neurogenic reflexes and local mediators. So we have transient vasoconstriction which normally minimizes blood loss at site of injury. So after vasoconstriction, we now have vasodilation, um, which normally occurs almost immediately. It's normally mediated by substances like mediators as histamine, bradykinin, nitric acid, and this normally leads to relaxation of smooth muscles in vessel walls. Its sole goal is to increase blood flow to the injured area, causing redness and warmth and promoting healing. Increased vascular permeability is the next step and this one occurs in venules, and this one will allow plasma proteins and leukocytes to exit the bloodstream. It facilitates the formation of exudate, leading to tissue swelling. As fluid exits the blood vessels, blood normally flows slowly, and this leads to stasis. This promotes accumulation of leukocytes along the endothelial walls, what is commonly referred to as margination. Then from there we have the adhesion and extravasation, right? Extravasation, whatever. So when you're looking at the process of leukocyte recruitment, right? It is important to review some of the steps. And in this case, we have margination, which is the first step of leukocyte recruitment. As blood flows slowly due to increased vascular permeability and stasis, leukocytes normally move closer to the endothelial of the blood vessels. Margination primarily occurs in venules where the flow is slower, and this one allows leukocytes to adhere to the vessel wall, right? And you can be able to see our marginations here. So they are flowing slowly along the wall. From margination, we go to rolling, which is an early step in leukocyte recruitment that slows down white blood cells, allowing them to interact with the endothelial cells of the blood vessels during inflammation. So, to facilitate this process, we have inflammatory signals like the cytokines, the tumor necrosis factor alpha, interleukin 1, which normally activate endothelial cells, leading to expression of selectins. So, we have E selectins and P selectin on the endothelial cells, which normally bind to L-selectin on leukocytes. Leukocytes then form transient and weak interactions with the endothelial cells, allowing them to roll along the vessel wall. Rolling normally slows leukocytes, preparing them to firm adhesion and migration into the inflamed tissue. From rolling, we go to adhesion, and the leukocytes will adhere to to the activated endothelium. Remember, we have selectins, where endothelial cells express selectins, that is P-selectin and E-selectin, in response to inflammatory mediators, which bind to the glycoproteins on the leukocytes, allowing transient adhesion. So after rolling on the endothelial surface, leukocytes will activate their integrins in response to chemokines. So activated integrins provide strong adhesion to the intracellular adhesion molecules, ICAM1 and ICAM and VCAM1 on the endothelium. From there, we go to transmigration, right? Remember, the process by which leukocytes move through endothelial cell layer to enter to the surrounding tissue, the inflamed place, is what we refer to as transmigration. Leukocytes move between endothelial cells, this paracellular migration, or through the cells themselves, transcellular migration. This is normally facilitated by breakdown of junctional complexes between endothelial cells, often mediated by inflammatory process. Remember, migration of leukocytes through the endothelium is referred to as transmigration or diapedesis, right? Diapedesis occurs predominantly in the post-capillary venules. That takes us to the other step of leukocyte recruitment, and this is chemotaxis. This is the directional movement of leukocyte toward the site of injury or infection. So leukocytes normally follow a gradient of chemotactic factors released from damaged tissues, pathogens, or other inflammatory cells. So these factors could include bacterial products, cytokines, components of complement system, products of lipoxygenase pathway of arachidonic acid metabolism. Okay, all right. So from there, they're going to activate, right? Once the site of inflammation, leukocytes are activated to perform their effector functions, right? Which could include phagocytosis, all right? Phagocytosis, degranulation, or release of inflammatory mediators to eliminate pathogens and facilitate tissue repair. In carrying out the process of phagocytosis, phagocytosis is a critical process in inflammatory response because it allows immune cells, particularly phagocytes like the macrophages and neutrophils, to engulf and digest harmful particles such as the pathogens or the dead tissues. So the process consists of three interrelated steps. Where we have first one is recognition and attachment. Phagocytes normally recognize invading particles through specific surface receptors that bind to the components of the microbes or the opsons. Opsons, these are host proteins that coat the microbes. Then these opsons can be pre-existing in the bloodstream or produced in response to the presence of microbe. And the binding of these opsons to their respective receptor on the leukocyte normally enhances phagocytosis, then takes it to engulfment. So once the phagocyte extends cytoplasmic projections called pseudopodia around the particle, engulfing it and forming a phagocytic vacuole known as the phagosome. This step is very crucial for internalization of the particles into the leukocyte. Then we come now to killing and degranulation. So the phagosome will fuse with the lysosomes to form a phagolysome, where the ingested material is exposed to destructive substances. The main mechanism of killing bacteria involve the use of reactive oxygen species, the ROS, which is an oxidative burst occurs, leading to increased oxygen consumption, glycogen catabolism, and production of the reactive oxygen species. This process is initiated by activation of the net oxidase in phagocytes, which converts oxygen to superoxidase ions. Superoxide then undergoes this mutation to form hydrogen peroxide. Then now we have the lysosomal enzymes. These include acid hydrolysis, which degrade the dead microorganisms. We have also enzymes such as elactase, which normally play a role in this degranulation process. So we have what we call leukocyte-induced tissue injury. As leukocytes are essential for defense against microbe, they can also mistakenly attack also other cells, right? Other cells. So, like during inflammation, leukocytes may inadvertently damage surrounding spectator tissue while targeting pathogens. It could also result into persistent infection, tissue clearance, and some of the autoimmune diseases resulting from leukocyte-induced injury. So, ladies and gentlemen, we have some molecules in leukocyte recruitment that play a key role. We have mention of the lectins, which normally mediate leukocyte rolling along the endothelial surface. We also have the integrins, which provides firm adhesion to the endothelium. Then you have the PEC1, which facilitates the transmigration of leukocytes across the vessel wall. And then chemokines, which are going to direct a leukocyte movement towards the site of inflammation. So those are the mediators that play critical role. In summary, we can say that we have several steps that are involved in leukocyte recruitment, and we can abbreviate them with the mnemonic My Rabbit ate three carrots, where M stands for margination, that we have said leukocytes moving towards the vessel wall in response to slowed blood flow during inflammation. Number two, R stands for rolling, where leukocytes roll along the endothelial surface, interacting with weakly via the selectins. Then we have adhesions, all right? This is pavimenting, where leukocytes adhere tightly to the endothelial cells through the integrins and the intercam and VCAM interactions, forming pavement of cells. Then that takes us to transmigration, which is also referred to as diapedesis, that involves leukocytes squeezing themselves through or between endothelial cells and entering the tissue. Lastly, we have chemotaxis, where leukocytes migrate through the tissue following chemical signals to reach the site of the injury. All right? Okay, guys. What are some of the outcomes of acute inflammation? Well, acute inflammation could result into complete resolution, where the injurious agent is eliminated and tissue returns to the normal with no lasting damage. Acute inflammation can also result into abscess formation if there is a lot of tissue destruction or severe infection. Pus, which is made up of dead cells, bacteria, and immune cells, may accumulate, leading to abscess formation. This process can also result in chronic inflammation. So, if the inflammation persists due to failure to eliminate the injurious agent, the condition may progress to chronic inflammation. Fibrosis is the last outcome where we have the scar formation, and this normally happens in the cases where we have extensive tissue damage. Healing may result into scar formation, like the keloid. So after looking at acute inflammation, we can also try and view the chronic inflammation, which is a prolonged inflammatory response lasting from several weeks to even years. All right, and it involves tissue injury, inflammation, and attempts at, of course, at healing simultaneously. It is a slow, progressive condition that can arise due to unresolved acute inflammation or as a primary response to certain triggers. So, we have some of the features of chronic inflammation. Like chronic inflammation normally lasts longer than acute inflammation, and we have said it could persist for weeks, months, or even years. Unlike acute inflammation, chronic inflammation is dominated by neutrophils, Chronic inflammation is characterized by the presence of macrophages, lymphocytes, and plasma cells. So, ongoing injury to tissues is normally the hallmark sign of a chronic inflammation, and it often leads to significant damage over time. We have fibroblasts that normally proliferate and provide collagen, leading to fibrosis, sometimes tissue remodeling. Simultaneously, blood vessels formation normally occurs, but the tissue may lose its normal structure and function. So those are some of the features of the chronic inflammation. Let's look at some of the causes. The first cause is persistent infections. So we have certain pathogens such as Mycobacteria tuberculosis for the TB, or Treponema pallidum for syphilis. Some fungi are difficult to eradicate, and this infection will elicit a delayed type of hypersensitivity reaction that's normally driven by T lymphocyte. So this organism persists in tissues, causing ongoing inflammation and immune response, which leads to tissue damage or granuloma formation. Immune mediated inflammatory response, which are hypersensitive diseases like the autoimmune diseases like rheumatoid arthritis, systemic lupus erythematosus, can occur when the immune system is mistakenly attacks the body's own tissues. Hypersensitivity reactions such as allergies and asthma could also involve excessive immune responses to environmental or endogenous triggers. So, these diseases can cause chronic inflammation as the immune system remains persistently activated, damaging tissues and organs over time. Right? Also, exogenous agents like the non-degradable substances like the silica, which is normally seen in silicosis, can lead to chronic inflammation in the lungs and other organs by continuously stimulating the immune system. We also have endogenous agents. Substances like elevated plasma lipids in blood can cause long-term inflammation in blood vessels, contributing to the development of disease like atherosclerosis, right? Pathological changes in chronic inflammation, you find that the hallmark of chronic inflammation is normally the infiltration of mononuclear cells, including the macrophages, the lymphocytes, and the plasma cell. So, like we have macrophages, where these cells play a central role by releasing cytokines and growth factors that sustain inflammation and promote tissue destruction and repair. Then we have the lymphocytes, which is made up of the T and B lymphocytes, which are involved in immune mediated processes that perpetuate chronic inflammation, especially in autoimmune diseases. Tissue destruction is also another pathological change in chronic inflammation, where ongoing inflammation normally leads to destruction of the affected tissue. Good example could be in the chronic lung disease or chronic hepatitis, where normal tissues can be replaced by the scar tissue. We also have fibrosis as another key change sign in chronic inflammation. As the body tries to repair the damage, fibroblasts normally lay down collagen, resulting in fibrosis, and this can lead to stiffening or dysfunction of affected organs, like for example the lung fibrosis or liver cirrhosis. So examples of chronic inflammation includes like peptic ulcers, where a peptic ulcer may start as an acute inflammation, but can become chronic if the underlying cause, for example, the helicobacteria persists. And this could lead to alternating periods of tissue damage and healing, resulting in both acute and chronic inflammatory features. As for the atherosclerosis, this condition normally involves chronic inflammation of the arterial walls due to prolonged exposure to lipids, leading to plaque formation, fibrosis, and narrowing of arteries. Rheumatoid arthritis is a chronic autoimmune condition where the immune system attacks the joints, leading to chronic inflammation and joint destruction and fibrosis over time. So we have some of the systemic effects of inflammation, like pyrexia. Of course, one of the most recognizable systemic effect of inflammation is fever. So when the body detects the presence of pathogen or inflammatory mediators, it normally releases cytokines like interleukin 1 and interleukin 6. These interleukin 1 and 6 normally act on the hypothalamus to raise the body's temperature. So fever is a defense mechanism that normally helps enhance our immune function and inhibit the growth of some pathogen. Another systemic effect of inflammation is acute phase response, where the liver plays a crucial role in systemic response to inflammation by producing a group of proteins referred to as acute phase protein. Example could include the C-reactive protein, the CRP, and the serum amyloid A, abbreviated as SAA. So these proteins will increase during inflammation and serve as markers of the acute phase response. They help with various aspects of the immune response, such as opsonization, which simply means marking pathogens for destruction, right? At the same time, promoting inflammation and modulating the immune system. The other systemic effect is leukocytosis. So, in response to inflammation, the body may release a higher number of white blood cells, particularly neutrophils, into the bloodstream. This will increase the leukocyte count, known as leukocytosis, and is a common systemic effect of inflammation. Inflammation can also lead to an increased heart rate as part of the body's effort to pump more blood, immune cells, and oxygen to the site of inflammation. Inflammation can also result in changes in blood vessels, where systemic inflammation can cause changes in blood vessel function. Inflammatory mediators can lead to vasodilation, which could lead to increase in blood flow to the inflamed area. However, it can also lead to increased vascular permeability, allowing immune cells and proteins to exit the bloodstream and reach the site of infection or injury. The other systemic effects include decreased appetite or anorexia. We have fatigue and malaise, joint and muscle and joint pain that going to result into myalgia and arthralgia. We have alteration in blood chemistry and impaired organ function. Right? Okay. So let's now try and compare the two forms of inflammation: acute inflammation, chronic inflammation. We can compare it in terms of duration, where you find acute is short term, whereas chronic is prolonged. In terms of onset, acute is rapid, chronic is gradual. What's the purpose of these two patterns? Acute inflammation is a protective response to injury or infection, while chronic inflammation is a persistent response to ongoing stimuli. What in terms of cellular infiltration, acute inflammation is we have neutrophils predominantly there. While chronic inflammation, we have cells like macrophages and lymphocytes. Tissue destruction, we have limited tissue damage in acute inflammation as compared to the chronic inflammation. Healing usually results into complete resolution for acute inflammation, while chronic inflammation often leads to tissue fibrosis and scarring. Inflammatory mediators, acute inflammation is primarily mediated by histamines and cytokines, while chronic inflammation we have the cytokines, the chemokines, and the enzymes. Effect on the blood vessels, you find that acute inflammation normally results into vasodilation and increased permeability, while chronic inflammation results into altered blood vessel structure and function. Systemic effects, they are very less in acute inflammation, but when you look at chronic inflammation, it could lead to systemic effects like the fever and the rest. So acute infections and minor injuries are good examples for the acute inflammation, while autoimmune diseases will serve as an example in the chronic inflammation, right? All right, guys. So that takes us to another subtopic where we're looking at wound healing and repair. Remember, all these processes we have inflammation is implicated in all these procedures. So wound healing is very crucial process for survival, and it normally restores tissue integrity after injury. This process normally occurs through main patterns. We have regeneration and repair. So regeneration involves replacement of damaged cells to restore tissue to its original state, while repair often results into scar formation when tissue damage. All right, so regeneration will all be relevant, especially when you are talking about epithelial cells, where they are able to regenerate. But scar formation will be involved when you're talking about connective tissue, right? Connective tissue will always result in the scar formation, right? Okay, so both these processes, regeneration and repair, are part of the body's response to injury and essential in maintaining function and structural stability. Wound healing is, of course, complex physiological process, and it restores tissue integrity. We have like 4 steps that are very essential in this process, starting with hemostasis, which is normally the immediate response. So it begins immediately after injury and lasts a few minutes with the aim to stop bleeding. Hemostasis involves processes like the first one where we have vasoconstriction. Blood vessels will constrict to reduce blood flow to the wound, and this is going to help in preventing excessive blood loss. Then after vasoconstriction, we go to platelet aggregation, where platelets adhere to the exposed collagen at the wound site, forming a platelet plug. Then now we have clot formation, where clotting factors are activated, leading to the formation of fibrin clot, which normally seals the wound and provides a scaffold for the later stages of healing. Step number 2 is inflammation, which is a defensive stage, of course, and starts within minutes and lasts about 3 to 5 days. The purpose of inflammation is simply to remove the debris, pathogens, dead cells, while also preparing the wound for tissue repair. So the process of inflammation involves vasodilation, where blood vessels dilate, increasing blood flow to the wound, bringing more immune cells like the neutrophils, macrophages, oxygen, and nutrients to the site of injury. Then we have neutrophils, which normally arrive fast and work to phagocytose bacteria and debris. Then neutrophils will be replaced with the macrophages, which will continue clearing the debris while secreting growth factors that normally stimulate tissue repair, okay, like the epidermal growth factor. Okay, so at the end of the process of inflammation, we're going to have the typical signs or the cardinal signs of inflammation. After inflammation, you go to proliferation, which is at a building stage, which begins day 4 and can last up to one to even to the third week. And the purpose of this proliferation is to rebuild the tissue matrix and close the wound. So proliferation involves a number of steps. We have angiogenesis, which involves formation of new blood vessels to form supply to the wound with oxygen and nutrients. Then we have the fibroplasia, like the fibroblasts, which normally produces collagen. They proliferate and synthesize collagen and intercellular matrix, forming the basis of new tissue. Then that takes us to granulation tissue formation. Granulation tissue is formed, filling the wound with new connective tissue and blood vessels. Then you have the re-epithelialization, where epithelial cells migrate across the wound bed to cover the wound surface. Then wound contraction, where myofibroblasts contract the wound, causing the edges to come together and reduce the wound size. Lastly, we have now the remodeling, which is the maturation, and this stage can last for weeks to months or even years depending on the wound size and type. The sole purpose of remodeling is to strengthen, re- reorganize the collagen in the wound, and achieve tissue strength and function. So we have the collagen remodeling, where type 3 collagen, which is the initial collagen, is normally replaced by a stronger, which is the type 1 collagen, and this increases the tensile strength of the wound. The wound also matures and the scar tissue becomes more organized though scar tissue is less elastic and weaker than the original tissue. It provides mechanical stability. Excessive blood vessels formed during the proliferation stage are reduced, giving the scar a pale appearance over time. So in summary, guys, wound healing normally happens in like 4 steps. We have hemostasis, which is the immediate clot formation to stop bleeding, followed by inflammation that helps remove the debris and infection control. Then proliferation, where there is tissue repair, granular tissue formation, and wound closure. And lastly, we have remodeling that involves strengthening and maturation of new tissue and scar formation. So healing can occur either we can all have several patterns of wound healing, where we have healing by first intention, healing by second intention, or by third intention. Okay, so fine. First intention is what we refer to as primary union, and this happens in a clean surgical wounds with minimal tissue damage, where the wound edges are closely approximated, e.g., the sutures. The key steps include, during the first 24 hours, neutrophils will be the first immune cells to arrive, and they work to clear pathogens and debris, while epithelial cells at the wound edges begin to proliferate and migrate to cover the wound. Then by the third day, macrophages replace the neutrophils and granulation tissue starts to form. Collagen synthesis begins, but it does not yet bridge the incision. By the fifth day, the wound is filled with granulation tissue and collagen fibers begin to bridge the incision, while the epithelium starts to regenerate and thicken. So by the second week onward, collagen deposition increases and the wound starts to blanch as blood vessels regress and scar matures. So healing by first intention typically results into minimal scar with very little contraction, because epithelial regeneration predominates over fibrosis. What about healing by second intention? That is second reunion. This one occurs when tissue loss is more extensive, as in large wounds, burns, abscesses. And so in this type of healing, we have large blood clots or scabs form on the wound surface. Then we have more intense inflammation occurring due to the larger volume of necrotic debris and exudate that needs to be cleared. We have abundant granulation tissue is formed, in which it's required to fill the larger wound space. As a result, secondary intention healing often results into formation of a large scar. Lastly, we have the wound contraction, where the myofibroblasts will play a significant role in wound contraction, which can help reduce the size of the large skin defects over time. So we have several differences between first intention and second intention, but we are looking at in terms of size of the clot, inflammation, granulation, and wound contraction, right? But what about the third intention? Third intention healing involves initially leaving an open wound, allowing it to drain, and later surgically closing it once it meets the criteria for primary intention, right? So this one involves hemostasis, inflammatory phase, proliferative, and remodeling phase. So if you compare all the types of wound healing, first intention, second intention, third intention, in terms of layers of tissue affected, you find that epidermis and dermis will be affected in the first intention, while secondary intention deals works on a wound that epidermis, dermis, and subcutaneous tissue have been affected. Healing by third intention, you find that in this case, the affected layers usually are the epidermis, dermis, and the subcutaneous tissue, and we have several characteristics for them. All right. Okay, guys. Now let's look at the second final concept here, and we have edema. Of course, edema, before you talk about edema, you have to look at the fluid compartments in the body. Did you know that 60% of our cells is made up of water? Did you know that? Yes. The human body is composed of water that is normally distributed in across different compartments. And all these compartments are primarily categorized as either intracellular or extracellular species. So, if you look at the first compartment, which is intracellular fluid, right? Intracellular fluid is the fluid contained within the cells of our body, and it accounts for approximately two-thirds, around 67 of the total body water. This compartment is very vital for cellular processes, including nutrient transport, energy production, and waste removal. Major electrolytes in the intracellular fluid include potassium, magnesium, and phosphate. So the intracellular fluid normally helps maintains the integrity and function of the cells by regulating osmotic balance through its electrolyte content. So you find that if you are looking at fluids in totality in our body, two-thirds of it will be found in the intracellular space, right? Okay, and the rest now will be found in the extracellular fluid, which will be made up of mostly interstitial, plasma, and others, right? All right, let's look at extracellular fluid space now. Of course, this represents a third of the total body water, and it is the fluid that is found outside the cell. It represents about a third. That's about 20 to 30% of the total body weight. This extracellular fluid is further divided into two major compartments where we have the interstitial fluid. This is fluid surrounding the tissues and the cell. Then we have the plasma, which is the liquid component of blood. What are the major electrolytes here in extracellular fluid? Well, we have sodium, chloride, and bicarbonate. Remember, the extracellular fluid is crucial for transporting nutrients, oxygen, and waste products to and from the cells. So the interstitial fluid, which is a subdivision of extracellular fluid, it normally occupies space between cells and surrounding tissue, and it represents about 75% of the total extracellular fluid. It acts as a medium through which nutrients, gases, waste products are exchanged between the blood and the cells. So edema will occur when there is excessive accumulation of interstitial fluid, often due to imbalance in the forces that regulate fluid movement, such as increased capillary permeability, venous obstruction, or low plasma proteins, like the hypoalbuminemia. When we have excessive fluid moving from vascular compartment to the interstitial space, swelling normally occurs, and this will lead to edema, which we are interested in for today. What about the plasma? Of course, plasma is also a subdivision of extracellular fluid, and it's the liquid portion of blood which comprises of about 25% of extracellular fluid. Remember, the 75% is for the interstitial. Plasma will circulate within the blood vessels, playing a crucial role in transporting blood cells, nutrients, hormones, and waste products. So we have plasma proteins, particularly albumin, which normally contribute to colloidal osmotic pressure, which normally helps maintain fluid balance between blood vessels and interstitial space. So edema normally results when there is fluid shift from the vascular space where there is plasma into the interstitial space, all right? Okay. We can say that edema normally occurs when there is an abnormal accumulation of fluid in the interstitial space, which results from the imbalance in the forces regulating fluid movement between blood vessels and surrounding tissues. So these forces are described by Stalin law of capillaries, which involves hydrostatic pressure, oncotic pressure, and all these mechanisms are affected by different causes, including increased vascular permeability and the rest. Maybe we could start by looking at one by one, but before we do that, remember, before you proceed, you as a nurse, you need to assess patient with edema, and you should be able to grade them into the four grade, any class of the four grades. Remember, starting with grade 1, grade 2, grade 3, grade 4. And this is used to assess the severity of edema. So we have mild edema, moderate edema, severe edema, and very severe edema. As for the grade 1, which is just mild edema, we have slight indentation, right? We have slight indentation of about 2 millimeter or less when pressing on the affected area, right? Okay, and the skin normally bounces back quickly, almost immediately. And in terms of signs or clinical appearance, we have minimal swelling, often not even visible, right? So what are some of these causes? Edema could be caused by increased hydrostatic pressure. It can also be caused because of immobility, or hypertension could also contribute. Edema can also be caused by peripheral vascular diseases, heart failure, we have renal failure, we have reduced oncotic pressure. And what can cause reduced oncotic pressure? When somebody is suffering from proteinuria, right, with a disease like nephrotic syndrome, or someone having protein losing enteropathy, or someone who is undergoing starvation, protein malnutrition, or someone with liver cirrhosis. All of these could contribute to reduce oncotic pressure. Also, we could have liver cirrhosis, which we have already at least mentioned, renal diseases, malnutrition, especially kwashiorkor, right? Kwashiorkor, which is a form of malnutrition, right? Inflammatory response, somebody undergoing an inflammatory response could also lead to also the edema process. We also have lymphatic obstruction as another cause, or intracellular edema, right? Intracellular edema. So we have several causes that can cause edema, right? For that matter, right? Alright guys, that marks the end of our presentation on the characteristics of a disease state, more so the inflammatory response. So in just as a way of revising, you should be able to state the 5 R's of inflammatory process. You should be able to describe the 3 steps of phagocytosis, describe 4 possible outcomes of acute inflammation, then at least be able to differentiate between acute inflammation and chronic inflammation. And lastly, be able to differentiate between first, second, and third intention in wound healing.